Today we have a presentation from Dr. KJ Seung on community-based care for MDR-TB. It gives me a great pleasure to introduce you to Dr. Seung. He's a medical doctor trained in infectious diseases and holds an academic position at the Brigham and Women's Hospital in the Division of Global Health and Equity, and has conducted research on treatment outcomes and side effects in MDR-TB patients who are co-infected with HIV. He began working for PIH in 2001 in Peru, where PIH scaled up MDR-TB treatment throughout the country. In 2007, Dr. Seung joined PIH Lesotho team to develop a comprehensive response to MDR-TB and XDR-TB in Lesotho per request of the Ministry of Health. This program, the first community-based MDR-TB program in Africa, utilizes a system of community health workers to support patients even in remote highland areas. Okay, so now I would like to give a floor to KJ.
And hopefully you can hear me now. I am going to turn off my camera now that everything is working, and I'm just going to start the lecture. There will be some quiz questions in between, and there will be some time for discussion where you should type your questions into the box, and I'll be able to see them directly and answer them. Community-based care for drug-resistant tuberculosis allows patients to receive drug-resistant TB treatment in their own community. This addresses one of the most serious barriers to adherence, the inconvenience of directly observed treatment. Treatment at home is more convenient for patients than traveling to a clinic each day. Let's start with the first question, shall we? After discharge from the hospital, an MDR-TB patient begins taking DOT at a health center near his home. Is this community-based care? So it looks like right here the answers are pretty evenly distributed. For the purpose of this talk, we will say that this is not exactly community-based care. From the point of view of a regular DOTS program, it is considered, a lot of people will say that is considered to be community-based care. For the purposes of this, and even within when you talk to different experts or people who are doing PMDT or drug-resistant TB programmatic work, sometimes the definitions may differ. But for the purposes of this lecture, once again, we'll say that, and I'll come back to this again, is that decentralization to a health center is not the same as really moving the care of the patient to the patient's home, because that is especially in certain countries that are more rural, more spaced out, is much more convenient. Now, in most recently, the diagnosis of MDR-TB has been increasing dramatically due to new technologies such as expert. And we're going to see a lot more patients being diagnosed, and we're going to see a lot more patients who need treatment. The community-based care model is very, very important. And what we see in a lot of countries is that even though, right now, we're starting to have waiting lists for treatment. Patients who have been diagnosed with drug-resistant tuberculosis, but they're waiting for a hospital bed in an MDR-TB hospital, and they can't be started on effective treatment. This is a major, major problem. In a lot of countries, they have a reliance in their national guidelines that patients need to be hospitalized, sometimes for the entire intensive phase of treatment, which could be 8 to 10 months. This congests the hospitals, so you have less room for patients who really need to be in a hospital because they're extremely sick, and creates waiting lists. It also increases the problem of nosocomial transmission. We know that in most of these hospitals, infection control is not always that great, and even though there have not been very many studies, there probably is a lot of transmission of drug-resistant strains to staff and to other patients. And the reality is that there is no program that is completely hospital-based, because sometimes they'll say you will be discharged after 4 months. Sometimes they say you'll be in the hospital for even the entire intensive phase, 8 to 10 months, but the patient still has to go home. And a lot of countries are experiencing that their patients, their MDR-TB patients, are defaulting from treatment once they leave the hospital. This is another reason to implement community-based care. And finally, I think that it gives a better understanding of the social background of their patients to the clinicians. Often as clinicians, as doctors and nurses, as program people, we start to lose sight of very specific issues that drug-resistant TB patients have. Certainly, all TB patients have these problems, but I think they are worse in some ways in drug-resistant TB patients. And it's very important to understand these things as program people, because there are ways that we can address these problems and help our patients get through treatment. Now, in this lecture, I'm going to be talking about a model. I don't want to be too prescriptive. I know that all of you are from very different countries. There's very different situations. In some countries, DRTB is extremely common. In others, it is much less common. Some countries are extremely large. Some of them are very spaced out. Some are much more urban than rural. I can tell you that community-based care is becoming more common in more countries compared to when we started, or when I started about 13 years ago. This is a picture from Lesotho. This is a small country in southern Africa. It's very rural. There are some places where doctors and nurses have to travel by plane into the mountain sites to provide care to patients who live there. And this is a place where community-based care has been implemented and is part of the national program. Another place is Peru. This is almost exactly the opposite. In cities like Lima, extremely dense, highly populated, MDR-TB is in the slums. Community-based care in this setting obviously is going to be different, but I think that many of the principles are going to be the same. So I think when you listen to this, I want you to not focus on the specific, because sometimes it really is impossible for me not to give examples from specific countries, but try to look at the overall, the general principles that are going to be similar to all countries. This, almost all the content is contained in a specific TB care manual. This is something we developed several years ago. We wrote the first draft based on our experiences from Peru and Lesotho. Clinicians and nurses worked on it. And then we had a consultative meeting where we invited international organizations, WHO, various NTP representatives, various NGO representatives, and we reviewed it. And again, with the same idea that we tried to give specific examples to provide some guidance, but try to be general enough so it's useful to a wide variety of countries. So this can be found on the Drug Resistant TB Network website. I think it's very good. There's a lot more detail in there than can be presented in this lecture, and I would encourage you to take a look at it. Now, as I said before, in every country, community-based care is not something that can stand on its own. You're definitely going to need hospital-based care. There are patients who are extremely sick, and we've all seen them. They can't walk, they can't feed themselves, they can't clean themselves. And this is what the function of the hospital is, to take care of very sick patients. The question is, do all MDR-TB patients, are they all that sick at the beginning of treatment? And the reality is that some patients are more sick later in treatment if, for example, you have very severe side effects. So you need to have, instead of saying that hospital care is just at the beginning of treatment, just for the first 3 months, just for during the injection phase of treatment, those rules are really set up often for the convenience of the program managers and not really fitting what the patient needs. The patient needs to be in the hospital when they are very sick. That can happen at any time during treatment. So the other thing that we discuss, usually there is an ambulatory phase of treatment because patients cannot stay in the hospital for 18 to 24 months. Now, a lot of countries are trying to go to a clinic-based model of care where patients go to the clinic every day to take their DOT, because this is what has been done in many countries for drug-susceptible TB. But there are real disadvantages of this, actually, even for drug-susceptible TB. And in urban areas, it will be more feasible to do this because the health centers or health posts tend to be closer to patients and to have a more decentralized network. In rural areas, if a patient lives 2 hours away from the health center, from the nearest health center, this becomes very, very difficult. And also in communities or in countries where MDR-TB maybe is not 20% of all cases, where it is less common, then again, when you decentralize down to very small health posts or health centers, they may only have one patient, and sometimes may have no patients. So this becomes also a problem for implementation. So what we're going to talk about in this lecture is decentralization or community-based care, but it is provided in the home. So a system of community health workers. So you extend your clinic-based, your hospital-based care, that clinical team directly into the home. This is the most convenient for the patient, and there are real advantages to this. In reality, I'm not actually. If most countries are going to have a mix of all three of these, there's going to be some hospital-based care, there's going to be some clinical-based care, clinic-based outpatient care, and then there should also be some community-based care that extends into the patient's home. That's the most efficient way. That's the most effective way of providing DRTB. In this lecture, many of the things we're going to talk about are directly related to this home-based community care, though some of the principles are also related to clinic-based outpatient care as well. So, just to sum up this last part of this section, we're not saying that community-based care and hospital-based care is mutually exclusive. Clearly, they're both necessary. And one of the things you need then is when you have an inpatient team and an outpatient team, you actually have to have better communication between the hospital and community teams. So this can actually be a problem that we'll talk about later. So TB programs then have to develop increased infrastructure to decentralize their care. And this can also be a burden upon TB programs. But the advantage is that the program now, instead of doing things that is convenient for the program, for the clinicians, for the doctors and nurses, you've developed a system that is flexible, that has multiple sites. There's a hospital, there's clinics, there is treatment in the home that can fit a patient's lifestyle, that can fit a patient's social situation. The importance of this really cannot be overemphasized, and is really the only way you're going to get good outcomes, which is what we all want. Definitely, this is my experience. The more rigid programs, or the program style, where they say we're going to focus on just one style of care, we're going to do it very well for patients for whom that style is very, very convenient. So if they live close to the clinic and they can do that, they do very, very well in treatment, and they're very adherent. But if for those patients who do not fit that style, who live far away, for instance, they tend to do very, very badly. So let me answer a couple of questions here. We're going to discuss a lot of things about nosocomial. Well, actually, we're not going to discuss nosocomial transmission. So I think that's a good question to answer right now. We should not discount the nosocomial transmission that happens in the hospitals. I think we've all been in these hospitals. Most of the time, there is no system of artificial ventilation. Sometimes even the natural ventilation is very, very poor. Now, one of the things inherently, I would say that community-based care, when you treat people in the home, it's inherently better for transmission, because you're simply not bringing together 10, 15, 20 infectious patients into a single space. And that's number one. Number two is they are surrounded by their family, but the reality is that those families have been already exposed. So you're not bringing them into a situation where they're exposing new people. And then the third thing is, if through community-based care you can reduce a waiting list, you can put patients on treatment faster. The number one way to reduce transmission of any type of TB is effective treatment. And so that should be the number one goal. And in my experience, my personal experience in working with community-based care, both in Lesotho and Peru, we have not had any instances of transmission, for example, to staff. And I think this has a lot to do. Of course, there are some measures taken in terms of N95 masks, but I think the biggest intervention is that we try to get patients on treatment as fast as possible, and that decreases the infectiousness of these patients. And I do think that the last question, yes, you do have to do a lot of counseling about the fear, because they do have a lot of fear about infection, but you have to do a lot of counseling with the family about other aspects of treatment as well. This is an advantage of community-based care. When you have a community health worker that is going into the patient's home, then you have a lot of opportunity to discuss all of these issues. There's as a clinician, we often feel, well, if we just take the patients out of the home, put them in the hospital, we'll solve all these problems. You solve them temporarily. Then the patient, remember, you have to send the patient back to the home. So if you haven't addressed these problems, if you haven't addressed the problem of stigma, of discrimination, of the fear of infection, they are going to have the same problem when you get discharged from the hospital. Let me go on then to the next section. A lot of the other questions that you're answering are very good, but we will actually discuss this later on in the lecture. So the most important thing here, I think, is the idea of a community team. I think the patients the places where this is done very well have created the community infrastructure, and a lot of that is HR to support patients in their home to take treatment. Let's go on to quiz number 2. And the question is, which is not part of the role of the community drug-resistant TB nurse? So the questions, the choices here are: observe the patient swallowing pills, visiting patient homes, training community health workers, and arranging for admission to the hospital. So this is very interesting. The correct answer here is that the community nurse should not be doing the DOT directly. All the other roles they should be doing, including arranging for admission to the hospital. This is a very difficult issue. Remember what I said before, which is that drug-resistant TB patients can require admission at any time during treatment, especially because of side effects and sometimes during other complications. And this issue of both admission and then discharge from the hospital is quite complicated. And it's very difficult to do if you just leave that up to the hospital team. So a community nurse who is essentially coordinating the aspects of the community care can fulfill this role extremely well. Let me go on to the next slide. And let's talk about the community team. Suppose we have a district. We're going to have some functions that are provided to all at the district level to all the different facilities or community-based team in that district. Certainly the pharmacy. For community-based care, there is not the pharmacy. I find this aspect of to be quite weak, that there is not enough management of second line stock, that there isn't enough, that the drug supply chain is not good. So getting, when you're decentralizing care to homes, to people in the community, we have to do a better job of making things very standardized for community health workers who may not be, they're not going to be nurses in many cases. And I'm actually going to talk about this later in the lecture. The M&E officer who needs to be supervising, to be collecting numbers, maintaining a database of the drug-resistant TB patients in that district. And then a laboratory technician. DRTB patients need laboratory tests, monitoring for side effects. Do these people need to be at a district office? Again, this can be, this can be flexible. In some places, this may be in the hospital, which usually does exist somewhere in that region. In the hospital team, you're going to have a DRTB clinician, often a physician, who's going to be managing the clinical aspect and be in charge of making the clinical decisions about starting patients on treatment, certainly managing inpatients with severe disease or side effects, and then seeing patients in the outpatient clinic who have been discharged from the hospital. Within the hospital, of course, there are other hospital nurses and ancillary staff. And these patients who are admitted to the hospital in the community-based care model are patients who are very, very sick. So even if they are fewer in number, this can be a significant amount of work. Now, the issue, what I think is the most important part, is having a dedicated community team. And what do I mean by that? So there should be a DRTB community nurse. Now, this nurse, I'm calling it a nurse. It doesn't have to necessarily be a nurse. Often, I think that nurses are very good. They have a mix of clinical and programmatic knowledge. And they are supervising community health workers, each of whom is in charge of one patient, providing DOT to usually one or two patients maximum. The role of a DRTB nurse, and we'll talk about this later, again, is to really coordinate all of the activities. And this is a role, this person does not exist in a lot of countries. And I think that when this person does not exist it really makes it difficult to implement a quality program in the community team. This is a very complicated treatment. Community health workers, no matter how dedicated, just simply do not have the clinical knowledge. You need somebody who is training, who is monitoring, who is supervising community health workers. A community nurse certainly has some clinical knowledge, but has to also communicate with that DRTB clinician, who may be based at the hospital, obviously, because that's a more medical setting, but there are going to be even clinical and medical aspects, complications, side effects that happen in the community. The DRTB supporter, we'll talk about this more extensively later, is providing DOT of second-line TB drugs. This usually is done 2 times a day. It's done in the patient's home. And then there's a lot of supportive aspects. It's not just giving drugs, but looking for side effects, monitoring for side effects, complications, helping the patient get to their consultations in the clinic, because this is also required as part of MDRTB care, but also providing education and emotional support to patients. So let's talk again about the DRTB community nurse, just to make things clear. So somebody who does not directly provide care to the patients, but who is available to monitor and supervise those people who are doing so, those community health workers. So there has to be some method of communication, even at odd hours of the night, because emergencies do happen, who is monitoring, supervising these community health workers on a regular basis, usually monthly. If there are problems in the home, can perform home visits. For example, the community health worker says, the patient is having a seizure, is acting very strangely. I think this patient is psychotic, is having some side effects of cycloserine. The community nurse can go out there directly and take a look and really assess the medical situation. Or sometimes there are adherence problems that are reported by the community health worker. The patient is under the influence of alcohol, is refusing to take treatment. Again, the community nurse can do a home visit to go out there. And because that, I think that both community health workers, but it's really the community health workers can also assess and be aware of socioeconomic problems, but the community nurse is the one who has the authority to take this to a higher level, to advocate for patients and get the social support. In some countries, we see that MDR-TB patients are eligible for social support, for transportation reimbursement that they don't access because there really isn't anybody to advocate for them. Finally, all the issues of coordination, so patients who need to be admitted, patients who need to be discharged, pharmacy teams who are creating monthly drug packs for patients. These need to get to community health workers. All of this has to be coordinated by the community nurse. And finally, integrated care. I think that this is more familiar to our colleagues in African settings with high HIV prevalences. It's really the same idea, is that you do not want your drug-resistant TB patient to have to go to multiple clinics to receive care for other comorbidities. So everything needs to be combined into one DRTB outpatient clinic. And the main reason for this is that it's more convenient for the patient. And we know from the HIV experience that this is going to make patients more adherent to all of their medications, to all of their treatments. But let's face it, there's another reason that's just as important: infection control. Do you really want your MDR-TB patient to be going to a diabetes clinic, to be going to an HIV clinic? This is really just not possible in a way that this aspect of infection control doesn't exist for many other types of chronic care. And I think in HIV high prevalence settings where most MDR-TB patients, usually it's about 70 or 80% or even 30% of patients are HIV positive, this is extremely the most important comorbidity that has to be managed. and you want this to be managed by your drug-resistant clinical team and your community team. There's a lot of training that has to happen. And I don't want to forget about family planning. This it's a very small thing. It's in the guidelines. It's very, very important. I think everybody who's running a program has had this issue of women who are getting pregnant while on treatment. We know this is very, very bad. It's easily avoided. But why does it keep happening is because we have not integrated our family planning into the care of the drug-resistant TB patients. So why don't we talk a little bit, answer a few more questions before we go on. So I think that we will actually talk a little bit more about the issues around the community health workers, and you know, I know that, for example, some people are saying that community health workers are not used for injections. How are we going to do this so how could we use community health workers for drug-resistant TB? This is a very, very common question, a common issue in a lot of countries. Let me go on actually, because I'll discuss this issue specifically in the next section. You know, when we're talking about a let's see here. Can I figure out how to? So now we're talking specifically about drug-resistant TB supporters. This is another quote from that manual, that community-based care uses compensated, trained, and supervised community DRTB supporters. Administration of DOT is labor-intensive. DRTB supporters should receive something in exchange for their work in supporting DRTB patients. You know, we have a lot of different types of community-based activities. I can tell you that the community health workers or the community-based care that if you really want to implement this model, this is a different level. It's more medical, it's more clinical, and so your program, your community-based program, has to reflect that, has to reflect the increased responsibilities that are given to community health workers. Let me actually quickly do quiz number 3, which is, who is an appropriate MDR-TB treatment supporter? Choices are mother of the patient, son of the patient, neighbor of the patient, or nurse. So, you know, here I would probably have to be completely honest, we probably do have two correct answers, which is, and one of them is a neighbor and another is a nurse. However, you know, there are, for example, countries where they say that nurses should be giving the DOT, but I would say the better answer is actually a neighbor. And in most countries, it will be very, very difficult to have a nurse to provide DOT twice a day for 2 years of treatment for every single MDR-TB patient in the country, because, you know, there really is a shortage of nurses already, and the amount, and even though that the act of doing providing DOT is a medical act, no question about it. It's not the same as doing community education, but it is not, you know, to be completely honest, it is not a high enough level. You know, to me, it is a waste of a nurse's experience and education to only provide DOT, and that includes injections as well. You know, in many countries, DRTB supporters, community health workers, have been trained to give injections. But let's talk about who then should be DRTB supporters. You know, there are pools of community health workers that have in almost every country, and I think that a lot of these qualifications and are similar to those supporters. That these it has to be acceptable to the patient and his or her family. There are a lot of issues with stigma and discrimination that we know in drug-resistant TB patients. So sometimes the community health worker in that community may not be acceptable. But at the same time, and I think a lot of you would accept a lot of these qualifications. Relatives are a real problem, and I think that in some countries, we know that using relatives to be treatment supporters or to do DOT for drug susceptible TB for DOTS treatment has actually been quite successful. In our experience, in my experience, it's a lot more difficult to do this with drug-resistant TB, and it's because drug-resistant TB is more medicalized. There are more side effects. You would be very, it makes perfect sense when you think about it. Is it possible for a mother to administer a drug that makes her daughter or son vomit every day when she gives it, to actually cause gastritis and to give abdominal pain? We don't expect parents to give cancer chemotherapy to their patients, to their children. And in the same way, I think it is unrealistic to expect relatives. The same thing happens when you have sons or daughters, children trying to provide DOT to their parents. It really changes the family relationship, the relationship that has been set up that exists between parents and their children. It's very difficult for relatives to act as good community health workers. But even when you're talking about a neighbor and not a nurse, obviously if you have a lot of resources in your country and you can have nurses that are going out on mobile teams and doing DOT twice a day, maybe you don't really have this problem. But in a lot of countries, you're going to want to use a neighbor, somebody who's close to the patient, who could go to the patient's home twice a day to observe treatment. This is usually not somebody with a lot of medical training. However, in a lot of countries, community health workers already know a lot about HIV or maternal health, so they've had some medical training to begin with. And injections, we know, especially there are certain types of injections, such as injectable contraceptives, that community health workers are trained to do. So it is possible to do. And intramuscular injections, there has to be very, very careful training. Usually we have the community nurse model this behavior to the patient and then prepare the patient, then actually inject the patient while the community health worker is watching. So each of these phases, and then the final phase is to watch the treatment supporter, the community health worker, prepare the medication and then inject the patient. And usually each of those phases, in Lesotho, this is where this is done. This particular model of training, usually each phase takes 1 week. And often the first phase might happen in the hospital. So if the patient is already in the hospital, you can bring the community health worker in to watch. And then again, you can do some of these phases in the hospital, and then you do the final phase outside the hospital just to make sure everything is okay. And within the setting where the patient is, the community health worker really understands how to give the injection. And it's been very, very successful. There are administrative barriers. There are issues. Usually the nurses' councils are very wary of this, but it's really a question of advocacy, of explaining the technical and the programmatic need for something like this. Because usually nurses are not very happy about having to travel for an hour or 2 hours to the patient's home to give an injection every day. Side effects, I think there was a question about this. It's really a very good opportunity because you have, I see, community-based care, you discharge the patient from the hospital, you give the patient some pills, and you say, okay, take these at home, I'll see you Call me if you're having any problems. This is not community-based care. You want to extend your medical practice into the home of the patient through a trained community health worker. And so that isn't just monitoring. We're not just trying to see that the patient takes the pills, but you also have the opportunity to look for side effects. And this is really just a question of training, of supervision. Is this possible for community health workers that are not, don't have any medical training? Yes, it is. The training, the care of a MDR-TB patient can go on for 24 months. So you have a lot of opportunities for refresher training for these community health workers, usually on a monthly basis. And community health workers, I have seen, can become very, very expert in watching, monitoring for side effects and recognizing side effects. When they're done with one patient, they get another one, and then you've got that pool of trained community health workers that you can call on. Finally, the supervision of DRTB supporters. This is, again, it's very important. The supervision that is required to do this sort of act, administration of drugs. There's nothing, I think, that is, we have been having community health workers give injections. We have giving them, we do have them provide medicines in the community to patients. But I think that this is so qualitatively it's not different, but it is a higher level. It's more than is required in other programs. So they do require really good supervision. This is an example you can see here where this is also from Lesotho, where they require each community health worker has a record every day of morning and night of what is provided to the patient. And even for community health workers with limited literacy in English, they are trained to write down and to draw exactly what is given morning, noon, and night. That's part of their supervision. There's daily recording of what they have to do. So not only this notebook, but also a treatment card. There's a monthly refresher training by the community nurse. There's a performance evaluation. They are instructed of ways to communicate with this community nurse, who has to be available 24 hours a day. And then there's also a hotline they can call if the community nurse is not available. There's another hotline that goes directly to the hospital that they can call, that they can flash, and then they'll get a call back since they don't use any airtime. So if they feel very, very supported, then it really is possible. And finally, there's this issue of reimbursements and incentives. It's very, very important. There are costs. Certainly, the community health worker has to be reimbursed for all costs that are incurred as part of their duties. For example, if you say the community health worker has to accompany the patient to the monthly clinic visit to be seen by the physician, then that is going to cost money. So you need to reimburse the community health worker as well as the reimbursement you give to the patient. But I think also you have to realize that on top of that, you do want to have a performance-based incentive. I think it's very, very effective. I don't think it's sustainable to expect community health workers to volunteer to do this type of work. It is, to be perfectly frank, it's life-threatening. They are coming into contact with patients who have an infectious disease. So I think that certainly you're not, there is a real feeling that they want to help their community, that they want to help other patients, that they want to help their neighbor. But at the same time, I don't think that is, completely sustainable. And even though it's not a salary, even though it's not complete compensation, it is a type of incentive. It is very, very effective for improving the quality of the work of the community health worker. And it is part of the guideline that we produced. So a few other questions. So, I think that the exact name of this, whether you call, we actually had a lot of discussions during the during our consultation. Should we call it a stipend? Should we call it a salary? Should we call it an incentive? I think this is going to depend on the country. And we know that, there are a lot of different types of community health workers too. I think that in most countries, the NTP is not going to want to hire to contract community health workers. However, we know that in a lot of countries there are NGOs who do contract community health workers, and these can also be incorporated into the national DRTB program. So perhaps they would not necessarily have a salary from the government or be a government employee, but they might have a salary from an NGO. And sometimes also not having a contract make things more flexible. So you may have, especially in countries that have low numbers of DRTB patients, you may want to have be able to take up a new community health worker and compensate that patient or provide that incentive for the time that community health worker is giving care to a patient. And then when that time period is over, then that incentive stops. So that gives you a lot of flexibility for a patient. And is it ethical to let a layperson inject a patient without the appropriate qualification? I think it is. I mean, I don't think it's ethical to do it without the appropriate qualification, without the proper training. But I think that our experience in a number of countries have shown, and I know even from the countries that you're coming from, that there are community-based programs that have used community health workers, that have used lay people. Training is extremely important. And do you need to have a medical background? Do you need to be a nurse to do an injection? And definitely, this is not necessary. That injections can be done with people without who are not nurses, if they are given the proper training, and that training should be pretty intensive and outlined as I've outlined previously. So let me go on to the next section here. And that is socioeconomic support. So food packages have two purposes for DRTB. They improve nutritional status and act as powerful adherence enablers. They should be considered a part of the treatment regimen and just as important as medications. So let's go on to the quiz question number 4. Which of the following statements about socioeconomic barriers to treatment to adherence is true? Socioeconomic barriers to treatment are most serious during the hospital phase of treatment because the patient is very sick. TB programs cannot afford to address socioeconomic problems faced by patients. Hospitalization is an excellent way to address socioeconomic problems by providing food and shelter to debilitated DRTB patients. DRTB patients face more socioeconomic barriers to adherence than normal TB patients. So I think that it looks like people here are choosing mostly number 4. And, I think that de facto, a lot of countries are using hospitalization to address a lot of these problems. And like I said before, it's not a good way to address socioeconomic problems. Yes, you can get a patient into the hospital, you can give that patient food and shelter. What happens when you discharge that patient? And we do have examples of countries where they don't provide any, patients are very happy in the hospital. They get discharged from the hospital and then there's just nothing. It's just a bag of pills. And that's a recipe for immediate default from treatment. And then the other thing is that hospitalization is a strange sort of halfway position. You're not really integrated back into your family, into your community. And this is always a problem. When you take somebody out of the community, how do you get back in again? They haven't been working for 8 months. They haven't been working for a year. The family may look differently upon them after being gone for so long. So this is one of the advantages of a community-based program. It's more complicated in a hospital, absolutely, but you start to solve those problems and to address those problems while they're still in the home, and that's, I think, is very, very important. So let's go on to talk a little bit more about socioeconomic issues. Food packages, this is common. So, again, I think that there are different ways of addressing socioeconomic issues. I think that it is important to address. Food packages are very popular. And, we do provide some guidelines. The World Food Program actually for, TB programs don't provide, often they don't have as much experience, but HIV programs, they definitely do. There are very good guidelines for HIV patients. And these guidelines, I think, are quite effective for TB patients, for drug-resistant TB patients, often who have HIV as well. So food packages is definitely one way of addressing this problem. Transportation, again, I see programs forgetting to address this issue. DRTB patients have to travel a lot more than regular patients. They have to travel for their X-ray. They have to go to to see the doctor every month. For over 24 months, if the patient is very far away, this can be a significant economic cost. So, depending on where the patient lives, if the patient lives 5 minutes away from the health center, you don't have to reimburse the patient. But certainly, if they're coming from an hour away, they have to take a taxi. They have to, in some countries, they may actually have to fly. If you're living, for example, in Indonesia, these have to be reimbursed by the program. Otherwise, this patient is just going to either default from treatment or just refuse to go into treatment. And temporary housing, even, this may come as a surprise to some of you, but this is very effective. And actually, also countries are already using this method of for some patients. You have patients who are very far away, live on another island, live in the mountains, live 5 hours away from the nearest health post. Yes, sometimes you can try to. Sometimes it's just easier to bring that patient into the city and to arrange for some temporary housing right next to the hospital, to a specialty center. And so he's not taking up a hospital bed, but is still very, very close. You don't want to do this for a number of reasons for all patients, but certainly there are going to be a small minority of patients where this can be very, very effective. And this could be the most cost-effective way of dealing with that patient's socioeconomic situation. This is a picture of a temporary house for patients who live in the mountains, who live very, very far away from any health system. And they are provided with a certain number, really everything that is, and then there's a food package that comes with them. This is usually a temporary situation until they're feeling much better, and that a community health worker can be found even in this very, very remote mountain setting. But it's very, very effective for patients who live in that situation. So here are patients who live in remote areas who might have, some side effects that need to be monitored closely. They're really too well to be in the hospital. And then unfortunately, there are patients, there are children who've been abandoned by their parents, or there have been people who've been abandoned by their spouses. Sometimes they're just family situations that cannot be resolved, and they really don't need to be in the hospital to resolve those issues. And this can be helpful for them as well. So before I go on to, so I think that, the cost for one DRTB patient for transportation and a food package, which I think is a reasonable, this has to be looked at very, very carefully, that you want to, I don't think that it's the best way to do it is, for example, for transportation. It really has to, often in a lot of countries, there are very strict rules about how you reimburse patients for transportation. And I would encourage you to use those rules that exist. And some countries have, even depending on the area and the district in which they live, or the exact village in which they live, this is the transportation reimbursement that we're going to give you, because that's the distance to the nearest health center. I think that's a really good way to go about it. And it's going to depend on the situation, the economic situation of the country, and the cost of transportation and the type of transportation that's being used. But I think that the one thing I would say is that even though I can't give you a very clear answer on how much it would cost, because it's going to differ on the setting, in every single instance, the cost of this is dwarfed by the amount of money that you're putting even just into the second-line TB drugs, which we know are extremely expensive, and the cost of the hospitalization, and the laboratory tests, the sputum tests, the TB laboratory. All of these things are much more expensive for MDR-TB treatment. I think that what we're finding is that if this is a small cost that you need to keep the patient into treatment and not lose all of that money that you spent in the first 8 months while they were in the hospital, it's really a small price to pay. Finally, I think I want to go on to supply chain management here. And we talked a little bit about the importance of this, which is often forgotten. And there is actually a last question here, which is, how many days of supply of cycloserine should be included in the monthly drug pack for an MDR-TB patient? So you have some options: 28 days, 30 days, 60 days, it depends on the month. So there is, I think that patient, what I think is very interesting about this issue is that we know, and I think that those colleagues who live in high HIV prevalence countries, this is very common for HIV positive patients. For an HIV program, you create a drug pack. In other words, you don't give a bunch of blister packs of pills, of loose pills or give to a patient saying, okay, take these at home. That you create a monthly drug pack. And we even know, the best way to do it. And if, usually you have the patient come back in 4 weeks, but you give the patient 30 days of medication, and then you know exactly how much is supposed to be back. So when you do that pill count on the next visit, because you've given 30 days of medication, then you know exactly that there's supposed to be 2 days left. So this is another way of checking the adherence of the patient. So let me just briefly talk about the issues surrounding. It's really surprisingly, I guess it's because, I actually don't really understand why this isn't done more often to create, everything that is needed for the patient. We do this for drug susceptible TB, right? So if you go to most countries, there's a GDF kit that has everything that's required for the patient in there for the entire elective treatment. HIV programs, like I said before, they count exactly the amount of drugs that are supposed to be taken during, of ARVs that are given to the patient. The same thing should be done for DRTB. The drug regimens are much more complicated than for HIV. And they should also include all other ancillary drugs, so treatment of side effects, and then if they are HIV positive or have diabetes, family planning, all of this should be included into this one monthly drug pack. Then at the end of those packs should be assembled by a pharmacy team. So you should have a standardized bag. You deliver those to the community health workers via the community team. And then at the end of the month, those patients come back to the clinic again. They pick up a new pack, and then you count those pills remaining. Almost everything should be done, but whatever's remaining, you put into the next month. And then if there's a patient who has died or defaulted, then you've got that extra drugs, and you can destroy that. Here's just an example of this little here. So you have actually a patient here, and then you have a community health worker, and this is the nurse. This right here is another nurse. She's holding the drug pack. This is very, very simple. Actually, they become more elaborate in recent years of the type of bag that they use. Here, they wanted something that is somehow would keep everything in one place. And so they note like all of the drugs are in this one bag. It does protect a little bit from temperature, but not so well. They got a lot of that later. But the point is that even at this very early stage, they were trying to make things as convenient as possible for the patients. Here's another picture, the last picture that I want to show. This is in the pharmacy. In the pharmacy, this is the patient's prescription, and then this is the patient's drug pack. So these are notice that, so he's got everything. He's got his prothionamide, he's got his pass. This is going to go later into that green drug bag. And here is an asthma inhaler. So this patient probably had some bronchospasm, needed this on a regular basis. This is also put into the drug pack. Here's omeprazole. This patient probably has some gastritis from his ethionamide or prothionamide and pass. So all of the ancillary drugs for the month, for all of the TB drugs, all of the HIV drugs are in one pack. It's convenient for the patient. And this is something that has to be included into your community-based program and for it to be successful. So I think I can we're really running out of time here. I think I can answer a few last questions. So, I think that there were some questions about let me go up here. So, is it feasible? So I think that community pharmacists to join MDR-TB care at the community level. I think that the pharmacy aspect of this is not. This is one of the weakest aspects that I see in drug-resistant, in community-based programs at the country level. I don't think it necessarily has to be at the community level. I think that the pharmacy aspect of this, which is really, and the most important aspect, is to create drug packs and then send them out to the community, then receive what's left, and then make up the new ones from the next month. That really takes all of that effort of sorting through pills away from the community nurse, away from the treatment supporters, away from the community health workers. Those can be, that can be done at a centralized level. So at the district level, sometimes even at a national level, if there aren't that many patients. So I think that even if it's hard to get, there's a lot of places where pharmacists or pharmacy technicians are not very common, but still there's a lot of opportunities, even if you just have a few, to get those involved if you have a well-functioning community-based system. And the strategies to use to report adverse drug reactions. It's very, very important. I think that it's very interesting. I can tell you that when we were first starting this, whenever you start off a community-based program, you have community health workers, even if they're very experienced with HIV. We all know the treatment of HIV is nothing compared to the treatment of drug-resistant TB. The amount of drugs and the side effects, and you really have to train community health workers on the side effects, and it takes some time. There are side effects that even the doctors and nurses will not know without training. And for example, to train a community health worker to recognize a seizure is very, very difficult. And you really can't explain it, but you have to have really good communication with those community health workers and a nurse, so that when something like that happens, then that's an opportunity for training. And then after the first year, after the second year, you start to develop a pool of trained community health workers that can, and that really starts to help you in your further training and your further treatment of patients. And then I can answer this. So there's a question. Is it possible to care for a patient with DRTB without hospitalizing? Absolutely. In Bangladesh, they're calling it 0 day. So, it can only happen if you have a good community-based program. So usually what countries do is that they start with a hospitalization, and then they start to develop this community-based program. Once you have a community nurse, once you have a system, once you have a nurse that can communicate very well and has a good communication with a doctor that's on call, you can now start. What you also find is that at the beginning of your program, all of your MDR-TB patients are extremely sick and they all need to be hospitalized anyway. But as your capacity for diagnosis increases, then they start to become much less sick. And you have patients who they don't even, they're actually working. You don't want to take them out of their home, stop them from working so they can just, fulfill some arbitrary guideline that requires hospitalization for 8 months, and they're really not happy to do that either. I mean, what's going to happen to their family? Who's going to support them? Who's going to support their kids if they have to go into the hospital? So these patients, you're going to find patients who don't need to be hospitalized. And yes, if you have developed a good community program, then you can start that patient just, they come into the clinic, it's the same thing. You start training the community health worker, the community nurse is right there in the clinic, and then that patient goes home and starts treatment. And this is something that we've done in Peru, in Lesotho, and that they're also starting to do in other programs in other countries. Yes, you may not be able to do that at the very, very beginning, but as that community-based program gets stronger, they will take on more and more, even of initiation of treatment. Is it feasible to introduce an intervention in a developing country like Bangladesh? I certainly hope so, because this is one of the places where we're trying to introduce community-based care. Bangladesh, I think, yes, it is extremely challenging. It's very, very poor. It's very, very large. You have patients who live in rural areas and then in very, very dense urban slums. But at the same time, we know that Bangladesh has a very strong history and much stronger than other cultures, than other countries. They have a very long experience with community health workers doing extremely complicated interventions. Just maybe not exactly like drug-resistant TB, but certainly almost as complicated as drug-resistant TB. So I'm very hopeful. We've started working. We work very closely with the NTP there. We also work with a lot of the very accomplished NGOs, and I think that Bangladesh is going to be a great place to, even with all the challenges, to introduce this model of care. So I think that I'm going to stop here right now. I'm very, very happy to provide this introduction. I would encourage you to look at the guide. There's a lot more detail there. We have a lot of discussions, and I think that there's going to be more opportunity to talk about community-based care. I would encourage you to try to come to one of our fellowships where you can really see. It's really helpful to talk to doctors and nurses who've been doing this for a long time. They have a different perspective about community-based care once they've had a couple of years experience under the belt. So it's nice to see an established community-based program like you can do. There is there's a fellowship in Peru and there's a fellowship in Lesotho. And thank you very, very much for your questions. They're very interesting, and I hope to be in contact with you all in the future.
Thank you, KJ, very much for your very interesting talk. Actually, this talk is fifth talk in our webinar series out of all 6 talks we have on these courses. I think it's the most challenging for actual implementation. because again, we have several talks on the drug regimen design and other talks about more kind of clinical, which we can control from the hospital point of view. But this talk is really challenging in terms of implementation on the field. That's why it's sometimes actually controversy in terms of infection control as well. That's why we have so many questions, and I'm glad that actually we answered most of them. About infection control questions, we have about 5 questions asking KJ about infection control in the community, how to take care of patient who is smear positive, or a DRTB patient who is smear positive when we start treatment at home, at the beginning, when we do initiation of treatment, etc. How to protect community health worker who is doing treatment for such patients. So I would like to, I didn't copy these questions and didn't give it to KJ because it's not our topic today. This topic was covered a couple of talks before. I think it was talk number 3, actually, by Edward Nardell. So I encourage you to go back to our DRTB Training Network website, the place where you register it for the webinars, and then you can find actually a presentation from Edward Nardell.